Hi, everybody. My name is Dr. Ilana Gurevich, and I am a naturopathic physician and an acupuncturist who is also board certified in naturopathic gastroenterology. Today, I'm going to be giving you guys a deep dive into autoimmunity and IBD through a clinical case perspective, brought to us by Diagnostic Solutions Laboratory, and really focusing on how I am utilizing the GI map stool test to help myself treat my very complicated inflammatory bowel disease patients. Let's start this conversation with a reminder about the gastrointestinal immune system. The human GI tract harbors the largest amount of bacteria or microbiota in the entire body. The job of the immune system in the GI tract is to maintain that very delicate balance between protecting the human against invading pathogens, but also tolerating the commensal species. With that immune equilibrium, it's really a very tight regulation, and there needs to be a lot of cooperation between the innate and the adaptive immune system. If there's an outside effect on that equilibrium, then you end up with digestive disorders like inflammatory bowel disease as one example. Here's a great image of everything that's happening in the gastrointestinal GI tract. We're going to focus on all of these individual immune aspects individually so we can kind of get a better understanding of what they do. The intraepithelial lymphocytes seen here are lymphocytes that are a specialized population found in the epithelial cell of the mucosal surface. They are the first line of defense and provide immediate immune response at the mucosal barrier. These are the cells that will exhibit activity like natural killer cell function, and they're related to both Th1 and Th2 responses. They offer barrier protection, and they play a role in maintaining the epithelial integrity and regulating the epithelial cell function, and they're mainly involved in antigen recognition and memory function. Dendritic cells seen here mediate tolerance to food antigens. They limit reactivity to the gut microbiota, and they're required for optimal responses to intestinal pathogens. They're heterogeneous in nature, but together they generate both regulatory and effective T cell responses, and they basically can protect the dendritic cells between the tight junctions of the epithelium so they can sense and sample luminal agents. B lymphocytes seen here are organized in gut-associated lymphoid tissue or GALT tissue, as well as regional lymph nodes. They can generate antigens, making up the largest population of the body that produces antibodies. 70 to 90% of the cells in the lamina propria will secrete IgA, and the remainder will secrete IgM. T lymphocytes behave a little bit differently. They will actually leave the thymus as naive cells, and then they'll go to the GALT tissue or the gut-associated lymphoid tissue through the circulatory process. When they get there, they will actually mature, and they will differentiate into either T regulatory cells or T helper cells. These are the cells that determine if inflammation is going to stay local or become more systemic. The GALT tissue is critically important for the human immune system. It makes up 70% of the immune system, and it mainly is in the small intestine, the cecal patch, large intestine, and the appendix. It has mainly plasma B cells, T cells, macrophages, and dendritic cells. The main antibody that it's producing is IgA. If you look at the GI tract, you'll find this lymphoid tissue organized in Peyer's patches, and most of the cells are immunologically naive, and then they mature once they're stimulated by an antigen. Now that we've done a refresher on the immune system, let's remind ourselves about the etiology of inflammatory bowel disease. To have this conversation, we really need to begin with cytokine dysregulation. That is one of the main aspects that go wrong with this particular disease. Cytokines are basically tiny proteins that are secreted by the immune system as well as non-immune cells to communicate with one another. They play a role in immune cells by allowing them to activate, proliferate, and differentiate. Currently, there are 5 different classes of cytokines. Interleukins coordinate immune response and inflammation. Tumor necrosis factors, or TNFs, defend against viruses and activate immune cells by eliciting an inflammatory response. Interferons defend against viruses and activate immune cells. Colony-stimulating factors cause blood and stem cells to proliferate proliferate and differentiate, and then transforming growth factors, or TGF-beta in particular, suppress differentiation and proliferation, like they slow down the immune system and they regulate cell growth and immune suppression. Let's look at cytokines' role in the inflammatory bowel disease patient and how it affects their disease. Let's start by looking at TNF-alpha, or tumor necrosis factor alpha. You'll know this pathway because there's lots of biologic drugs that target this pathway in particular to try to treat inflammatory bowel disease. TNF-alpha is a pro-inflammatory cytokine that's made by macrophages, monocytes, and T cells. It will promote inflammation through lots of different mechanisms, including production of interleukin-1 beta and interleukin-6. It is increased in inflammatory bowel disease patients, and the overproduction is thought to contribute to the intestinal inflammatory response. With a dysregulation of the TNF-alpha signaling, the balance between the pro-inflammatory cytokines and the anti-inflammatory cytokines are disrupted, and the imbalance leads to the activation of other downstream inflammatory pathways. Those downstream signaling abnormalities will cause further dysregulation of the inflammatory pathways, and NF-kappa beta will then also contribute to this chronic inflammatory cascade. As far as pharmaceuticals that act directly on the TNF-alpha pathway to address inflammatory bowel disease, as well as other diseases, we have a fair amount of drugs that act directly on this pathway. That includes the brand drugs, but also the new biosimilar drugs, which are basically generic biologic agents. For a long time in the world of inflammatory bowel disease, this was the only cytokine that was targeted. That's come a long way, but we do have a lot of drugs that target the TNF-alpha pathways. Unfortunately, 30 to 40% of patients may not respond to initial TNF-alpha therapy or may lose response over time. Another thing that can go wrong with inflammatory bowel disease patients is affecting the axis of interleukin 23 and interleukin 17, IL-23 and IL-17. Just a reminder, the interleukin's job is to coordinate immune response and inflammation. With inflammatory bowel disease patients, the IL-23, IL-17 axis becomes overactive, which can lead to an excess of inflammation. Intestinal macrophages, dendritic cells, and epithelial cells can then overreact, causing tissue damage. And then interleukin 23 will promote the production of interleukin 17 by the immune system, and that will trigger inflammatory responses in the GI tract that can contribute to the chronic inflammation and tissue damage that we see, and it will promote a Th17 or autoimmune-like response. Th17 cells produce pro-inflammatory cytokines like interleukin 17A, interleukin 17F, and interleukin 22. Here's a list of drugs that are acting specifically on the interleukin 17, interleukin 23 pathways. We see some of these drugs used very commonly in our practice, and then other drugs are coming in the pipeline right now, or we're starting to see them used for a variety of other rheumatologic disorders. Historically speaking, drugs will initially start in the rheumatology world and then will become repurposed for the inflammatory bowel disease world. Interleukin 6 is another place where we can have disruption for the inflammatory bowel disease patient. If we have an elevation of interleukin 6 either in the plasma and the inflamed mucosa of the GI tract, this contributes to inflammation and plays a role in intestinal tissue integrity lacking or getting broken down. The interleukin 6 pathway will become overactive, and then there's a lot of signaling that is associated with chronic inflammation. Interleukin 6 will also lead to the production of pro-inflammatory cytokines like interferon gamma, TNF-alpha, and interleukin 1 beta, and the increased expression of adhesion proteins, which promote the activation of inflammatory cells in the intestine. Here's a list of drugs that target the interleukin 6 pathway within the human body. One of the things that we can utilize is this ability for running a CytoDX test, which is a test put out by Diagnostic Solutions Lab that looks at different cytokine pathways. If we can see what cytokine pathways are revving aggressively for a patient, that can really help us inform a decision of which biologic agent they should be started at, and we can try to you choose an agent that's more likely to support them based on their current cytokine pathways. Dysbiosis is another thing that definitely goes wrong with the inflammatory bowel disease patient. Dysbiosis most likely contributes to inflammatory bowel disease. There are multiple large studies that link acute gastroenteritis with the knowledge of patients getting a significant uptick in diagnosis of inflammatory bowel disease within 6 months of the event. There's a 5-fold increase in developing IBD if you have an IBS diagnosis. And also there's a risk of developing inflammatory bowel disease within a 12-month period after suffering from either a Salmonella or a Campylobacter gastroenteritis. Let's take a quick look at the healthy microbiota versus an inflammatory bowel disease microbiota. A healthy GI tract has a lot of diversity, a richness in different microbial species. The two major phyla that we have is Firmicutes and Bacteroides, which together make up about 90% of the gut microbiota. The presence of key genres like Bacteroides, Bifidobacterium, and Faecalibacterium give the ability to make short-chain fatty acids. Those short-chain fatty acids then support a diverse immune system and also support the enterocytes within the large bowel. A dysbiosis pattern is often seen in inflammatory bowel disease patients. We see an imbalance between the beneficial and the harmful bacteria, which make up the intestinal barrier, and that can trigger inflammation. We see less diversity, a decline in both Firmicutes and Bacteroides species. We see a depletion of beneficial bacteria, so a decline in the Faecalibacterium prausnitzii species, the Roseburia homini species, and those are essential for gut health. We see an overgrowth in anaerobes like E. coli, a reduction in short-chain fatty acid producers, and then fewer total bacterial species compared to a healthy individual. And what conversation would we be able to have about inflammatory bowel disease if we don't talk about the role that diet plays within it? This is really where alternative medicine or functional medicine providers bloom, is we have an understanding of how diet plays a role in disease. Food antigens are thought to trigger an immunological response, resulting in the development of inflammatory bowel disease. Specific pathogenic antigens have not been identified, but there seems to be a standard Western diet that's full of high processed, fried, and sugary foods that is definitively associated with an increased risk of developing Crohn's disease and also likely developing ulcerative colitis. Using a food explorer test can often help us understand with patients why are they reacting to certain foods. It gives us an understanding of what the immune system is doing and how it's revving to different foods so that we can make some changes to bring the patient more comfort. Inflammatory bowel disease patients generally have a reduced microbiome diversity. The standard American diet, full of high refined carbs, saturated fats, and animal proteins, lead to a further decrease of the short-chain fatty acids that help support both the microbiota and the intestinal cells. They also have intestinal permeability. Processed food with lots of emulsifiers and preservatives will weaken the GI's mucus layer, and then the bacteria and antigens will enter and trigger an inflammatory response because they're not supposed to be there. The standard American diet is low in anti-inflammatory fruits, vegetables, fiber, and high in saturated processed fats and sugars, which in of itself will promote inflammation. And then a low fiber intake from the standard American diet will hinder short-chain fatty acid production and reduce protective gut factors. We do have some strong correlations with diet and inflammatory bowel disease. There seems to be an early negative reaction to cow's milk protein in infancy, and that's a theorized potential cause of inflammatory bowel disease. A survey of inflammatory bowel disease patients noted that cow milk hypersensitivity was more common in patients with ulcerative colitis and Crohn's as compared to healthy controls. As we talked about earlier, increased dietary refined sugar intake is also linked to the development of inflammatory bowel disease, especially Crohn's, and long-term intake of dietary fiber, like that come from fruits and vegetables, show a decreased risk of developing Crohn's. Not so much ulcerative colitis yet, but there is that potential decreased risk for Crohn's. Increased dietary intake of total fat, animal fat, polyunsaturated fatty acids, and milk proteins have been correlated with an increased incidence of both ulcerative colitis and Crohn's, and also an increased relapse rate of UC. Patients that have a higher intake of omega-3 fatty acids and a lower intake of omega-6 fatty acids seem to have a lower risk of developing Crohn's disease. Whew, that was a whole lot of information. Now let's dive into a case. We're going to talk first about Rebecca, who's a patient with ulcerative colitis. Rebecca came to us as a 29-year-old female who had very recently been diagnosed with ulcerative colitis. She was actually a referral from another naturopath that lived in a city about 3 hours from us, and she relocated to Portland, Oregon to actually establish and develop care with our team. She had a history prior to diagnosis of every summer having some kind of GI flare. This summer was especially bad. It's the worst it's ever been. And so she had recently finally gotten a colonoscopy, and the diagnosis was ulcerative proctitis. They started her on oral and rectal treatment of mesalamine, which is a non-steroidal anti-inflammatory agent. The naturopath added in glutamine and probiotics to her treatment plan. 6 months after diagnosis, she started having pain in her right labia and she became feverish. She was then diagnosed with a perianal and right labial abscess or fistula, and they actually changed her diagnosis to Crohn's disease and started her on biosimilar infliximab, which is that TNF alpha. She was hospitalized and admitted for surgery for the abscess or fistula, and they placed a ceton to prevent it from closing up again. That's when she moved to Portland to seek medical care while living with her sister and establishing care with us. Let's quickly dive into what an ulcerative colitis patient will look like when they establish in your practice. This is an image of a UC intestine. This is a pretty severe case. Let's jump into what the symptoms will look like. Bleeding and diarrhea are the most common symptoms that we see with UC patients. They might also experience colicky abdominal pain, urgency, rectal spasm or tenesmus, and bowel incontinence. The severity of their disease will often predict how severe their symptoms are. When we are looking to assess a UC patient's disease, in the literature and also in clinic, we'll utilize a Mayo scoring system. Patients with mild disease will have 4 or fewer bowel movements per day, and they may or may not have blood. Generally, there's no risks of systemic toxicity. They have a normal sedge rate or inflammatory markers, and if they have pain, it's generally mild, crampy pain, and they may also have periods of constipation in between the diarrhea. Moderate UC are patients who present with more than four loose bloody bowel movements a day. They might start showing systemic symptoms like a mild anemia, but generally they will not need blood transfusion. It's not that severe yet. And if they have abdominal pain, they generally don't report it as very severe. They'll have minimal signs of systemic toxicity. They rarely have low-grade fevers, but it is possible. And usually they have adequate nutrition, but they might start having some weight loss if it's going from moderate to severe. Severe UC patients are a lot more difficult to manage. The patients have 5 or more loose bloody bowel movements per day. They'll usually have severe cramping. They'll show systemic toxicity like a fever, increased heart rate, anemia, and then elevated inflammation, and these patients might have rapid weight loss. The scariest part of having an acute severe UC condition is it could really cause some very significant issues. Severe acute hemorrhaging rectally, if they cannot get their bleeding under control, is considered a surgical emergency, and they absolutely are at risk to developing fulminant colitis or toxic megacolon. With severe patients that are at risk of developing fulminant colitis, they have more than 10 stools per day, continuous bleeding, abdominal pain and distension, systemic severe symptoms, and if they develop a fulminant colitis, then they are much more at risk of developing a megacolon, and that can lead to a surgical emergency. One of our most useful markers with these patients is a fecal calprotectin. Fecal calprotectin is an abundantly studied and very reliable marker for detecting inflammatory aspects of inflammatory bowel disease, and it can help you differentiate IBD from IBS. Basically, the calprotectin is a calcium-binding protein that's found in neutrophils, monocytes, macrophages, and gut epithelial cells. In inflammatory bowel disease, the neutrophils will migrate over to the inflamed mucosal tissue, and that will increase the calprotectin into the stool. The calprotectin level correlates with inflammatory severity, matching both histological and endoscopic findings. It's got a sensitivity of 93% and a specificity of 96% for large bowel inflammatory bowel disease. Elevated levels can also indicate colorectal cancer, diverticular disease that's active, and any infectious gastroenteritis. And so if they're having an acute episode, it's not a useful marker, but if they're having a chronic diarrhea episode, it's a very useful marker. There is not a clear consensus about the cutoff for a calprotectin marker. So calprotectin is a well-established inflammatory bowel disease marker, and it definitely has a threshold, but that cutoff is not clear. When we're talking about utilizing the calprotectin that we see in Diagnostic Solutions lab ranges, they have a cutoff of anywhere below 173. Anywhere that's under 50 usually suggests histological remission. Around 100 more accurately differentiates inflammatory bowel disease from non-IBD cases. 400 to 1,000 suggests ranges of monitoring active inflammatory bowel disease. And over 600 is strongly correlative with inflammatory bowel disease presence. Different labs will use different assay methods, including monoclonal versus polyclonal antibodies, to differentiate the caliber. Results should be monitored using the same laboratory and testing platform. Don't use one lab and then compare it to another lab. That's comparing apples to oranges. The laboratories have to establish their own clinically relevant ranges based on the validation technology that they use. Let's get back to Rebecca. What did we do on Rebecca's initial intake? The first thing we did was we ran a stool test. After the stool test, she began Saccharomyces boulardii probiotics, and she restarted her mesalamine at 1,000 milligrams rectally every day at bedtime. Here is her blood panel that she brought in. Her hemoglobin and hematocrit were both decreased, so she was showing some mild anemia. She had a total iron of 24 and a percent saturation of 8, which are both very low. Her ferritin was a 25, which is not awesome, but not terrible. HSCRP, or a systemic inflammatory marker, was very elevated at 9.5, and her methylmalonic acid was very elevated at 419, which means she was having a hard time absorbing her vitamin B12. This is the GI map that we ran with her during that first visit. It's not looking great. She had absolutely no detectable Akkermansies. Her Bacteroides was low. Firmicutes was normal, and because of that, the ratio was tending towards getting higher. She had a presence of opportunistic species, including Bacillus, Morganella, Staph, Strep, and Escherichia species were all elevated. She was showing blood in the stool. Her EAP, which is an inflammatory marker, was very elevated, as was her zonulin at 539.3. What we had her do is continue on Saccharomyces boulardii probiotic, and then we had her add in a class 1 and a class 3 probiotic. She began N-acetylglucosamine, glutamine for mucosal support and an attempt to heal up the fistula. She began turmeric at 2,000 milligrams twice a day, methylcobalamin IM injections for 10 doses. We decided to give her an iron infusion at 3 doses due to the lower hemoglobin hematocrit and the borderline low ferritin, and she began low-dose naltrexone. Let's talk about why we gave her probiotics. At this point, it's clearly known that inflammatory bowel disease has a large microbiome disorder component, and replenishing the GI with healthy probiotics seems to be especially useful, especially when we're discussing ulcerative colitis and sometimes with Crohn's. So with probiotics, we're looking at 4 different classes. We added in a class 1 probiotic, which is the lactic acid producers, Lactobacillus acidophilus, the Bifidobacter species, and Streptococcus thermophilus were all included in her class 1 protocol. She was already on a class 2 probiotic, Saccharomyces boulardii. We added in class 3 probiotics, Bacillus coagulans and Bacillus subtilis. And then we considered adding in a class 4 probiotic, E. coli Nissol, but it's not available in the US, only available in Canada. So why? Why did we add probiotics into her mix? Studies have linked probiotic use to preserving intestinal integrity of the GI lining. It is a useful tool when you follow up an infection for somebody or when they're having acute issues. Studies have shown that using probiotics will decrease the tight junction breakdown between enterocytes. It has been shown to increase buildup of tight junctions in the intestines. It's anti-inflammatory, and it has antimicrobial effects on the GI lumen as well. S. boulardii is a class 2 probiotic, and that is actually a yeast. It's believed to be a strain of Saccharomyces cerevisiae family, which is in the yeast family that makes up brewer's or baker's yeast. Saccharomyces boulardii has been used medically and has been shown to be effective for treating diarrhea, antibiotic-induced diarrhea, traveler's diarrhea, C. diff infections, and acne. Here are some examples of clinical trials that have been done utilizing Saccharomyces boulardii for different subsets to see their response for IBD, and generally the studies are pretty positive. Saccharomyces boulardii has been found to upregulate the E-cadherin transmembrane glycoprotein found in the adherens junctions. In both IBS and IBD, these junctions were found to be downregulated, and that leads to intestinal permeability. Saccharomyces boulardii has been found to significantly increase the amount of E-cadherins glycoproteins within the cell and decrease intestinal permeability. When looking at dosing of Saccharomyces boulardii, this can be a little bit confusing because you either see the dosing in a CFU, colony forming unit dose, or a milligram dose. It's a little bit tricky because fungi don't form colonies, but yet we kept the CFU terminology that we use with bacteria. Just for your knowledge, 5 billion CFUs equals 250 milligrams. For inflammatory bowel disease patients, we'll use 20 billion CFUs in divided doses. IBS patients will utilize 1.5 to 5 billion twice daily. And to prevent traveler's diarrhea, the dose range can be anywhere from 2 billion to 15 billion. The higher the dose, the higher likelihood of prevention. Class 3 probiotics are also known as spore-forming probiotics or soil-based probiotics. We used to be ubiquitously exposed to the soil and the water, and they used to always be present. That was before we started treating our water or really separating ourselves away from the earth. These species are not active in the soil. They maintain their spore shape. They can survive in their spore form irradiation, desiccation, competition. They really can survive a lot. And in fact, they stay solid in the stomach, but once they enter the small intestine, they open up and leave their spore-based formation, and that's when they start functioning like a probiotic. There are 2 animal trials looking at class 3 or spore-forming probiotics for ulcerative colitis. Both are showing efficacy utilizing the spore-based probiotics. However, I will say that the studies are funded by the manufacturer, so there is a little bit of a question mark there. There is some mixed data that says that spore-forming probiotics might increase Th17 or the autoimmune response, but there's also other data that says that that's not as much of a problem. E. coli Nissl is our class 4 probiotic. It is an E. coli Nissl 1917, and it's been found to be as effective as mesalamine during ulcerative colitis flares. The problem with E. coli Nissl is it's not available in the United States. You have to get it through Canada or anywhere in the rest of the world. There are quite a few meta-analyses looking at probiotic efficacy in the ulcerative colitis population. We can see over here on the right that almost all of those studies show some kind of net benefit using probiotics for ulcerative colitis. We also have a fair amount of data looking at probiotics for Crohn's disease. And, we can see in those studies, it's not as clear cut. There's definitely data that says there's a benefit for Crohn's disease, but there's also some data that says no benefit at all, or it might even cause harm. Probiotics for Crohn's are not the slam dunk that they are for ulcerative colitis. Curcumin and turmeric. Why did we use these substances? Curcumin comes from the spice turmeric, and it exhibits a lot of anti-inflammatory properties. It's anti-inflammatory, antioxidant, anti-cancer, antiviral, neurotrophic activity. It has been shown to decrease hsCRP, TNF-alpha, and interleukin 6. The theoretical issue with curcumin is it's not bioavailable, and because of that, we see low concentrations within the blood and high excretion in the stool. However, with the inflammatory bowel disease patient, that's our goal. Our goal is to see high amounts within the GI tract so we can keep the anti-inflammatory properties locally. Curcumin has also been shown to have a significant amount of effects on the GI. It has been shown to improve biodiversity within the microbiome, improve tight junctions of the mucosa of the GI tract, helps with mitochondrial function, and helps, regulate the endoplasmic reticulum. It lowers ALT, AST of the liver, and TNF alpha and LPS. It upregulates occludin in the intestinal mucosa, which protects the cells, and it's also been found to have antibacterial, antiparasitic, and antifungal activity. Low-dose naltrexone is another very useful agent that we'll often use with these patients. It's a pharmaceutical drug that's been approved for opiate and alcohol addiction in the 25 to 150 milligram range. There's a lot of clinical case studies that are showing low-dose naltrexone use and lots of discussion in the online community to treat autoimmune diseases in different stages. There was this very, very interesting study put out by Norway. It was a quasi-retrospective study where basically the Norwegian population was introduced to the concept of using low-dose naltrexone for autoimmune diseases on a television documentary that aired on national TV. They took patients who then took this knowledge and asked their doctor for a prescription for naltrexone, and they tracked those patients, matched them to an ICD-10 code or a diagnosis code, and then with that diagnosis code, track the patients going forward for 2 years utilizing pharmaceuticals, and then also going back for 2 years to see the pharmaceuticals that they had utilized in the past. What it showed is that naltrexone, out of all of the 27,000 patients that they looked at, about 4,500-ish were inflammatory bowel disease patients, and about 4,185 prescriptions were dispensed. What we found, about 2/3 of the population that were prescribed naltrexone continued to utilize it. A third fell off. And what we found was a net 12% decrease in pharmaceutical use while taking naltrexone. But the majority of that decrease was actually a net decrease of using intestinal corticosteroids. So it seems like naltrexone's main efficacy has more to do with the fact that if you're on it, it prevents an acute flare, hence you need intestinal corticosteroids less than really getting you out of the flare. Initially, we were able to get Rebecca quite stable. She was also actually able to move back to Bend. However, in Bend, her living situation became really, really stressful, and she went into another flare. She reran a calprotectin. It came back as 1,700. The gastro wanted to initiate prednisone to get her out of that acuity, but she decided to continue on Inflectra, the biologic. She started chlorella, continued on naltrexone, turmeric, fish oil, and Saccharomyces boulardii. Even on that whole regimen, she was having 4 bowel movements per day. They were watery bowel movements. She would have Bristol 7 bowel movements exclusively that would last a week or 2. They were urgent, bloody, and then the fecal blood coming from the fistula also sparked things to go wrong. When she reached back in with us to let us know what was happening, we pretty drastically changed up her treatment plan. We initiated Qingjai and Shengjiang, or indigo naturalis and fresh ginger, 500 milligrams of the Qingjai or indigo naturalis, and 150 milligrams of the Shengjiang or fresh ginger. We started her on 1 capsule of each to see how she could do, and then we had her slowly increase to 2 capsules twice daily, or to tolerance. The other thing we noticed is she was most likely having some histamine production or histamine overstimulation, so we tried to also initiate cromolyn sodium at 2 vials or 200 milligrams diluted in water 4 times per day before meals to see if she could tolerate it. Mesalamine enemas were also reinitiated, and she was asked to retain 1 bag at bedtime instead of using the suppositories. We had her restart quercetin and nettles at 3 caps 1 daily each, mainly because there was a lot of histamine going on for her, and then continue with the chlorella, which she had started herself, at 1 pill 3 times a day. And you can work up as much as 2 to 8 pills 3 times a day to see how she's doing. Why did we use indigo naturalis? This happens to be one of my favorite herbs to use for ulcerative colitis. There are multiple multi-center double-blind placebo-controlled trials using indigo naturalis or Qing Dai compared to placebo. What we look at in these studies is the primary endpoint, which is where is their disease at week 8. And then the secondary endpoint is can they hold that clinical remission as defined by a Mayo score of less than 2. What happened is that there seems to be a dose-dependent linear trend to patient response. A slow increase in dose, patients do better, and many of them were able to establish a clinical remission by the 8-week mark. And this is completely what I see in clinical practice. We also see a significant amount of mucosal healing or an improvement in the mucosal healing. So 56.5% of indigo naturalis patients versus 13.6% of control groups were able to establish mucosal healing just using indigo naturalis. After initiating the indigo naturalis treatment, she worked up to 1,000 milligrams or 2 capsules twice daily, and at the 4th day, she completely stopped bleeding. Her bowel urgency resolved, and now she was having 3 Bristol 4 bowel movements per day. She was able to tolerate coffee for the first time in 6 months, and she didn't really notice a significant difference with the mast cell support that we were giving her. The cromolyn and the antihistamine herbs didn't make a difference, so she discontinued those. On her own, she decided to discontinue the mesalamine enemas. She didn't think they were really doing anything. And then we ran a calprotectin, and 4 weeks into the indigo naturalis, she had dropped to 112. She was doing great. This is how I often see this herb work. Let's now switch gears and look at Crohn's disease. So we're going to talk about Tim, a Crohn's disease patient. Tim presented to clinic as a 58-year-old male who had been diagnosed with Crohn's disease at age 50. He had basically been in a constant flare since diagnosis. He had chronic diarrhea, weight loss, pain, and fatigue. He was an exterminator by trade, and so he was exposed to pesticides daily and had been for the last 20 years. He was frequently having bowel accidents at work. He would bring 2 to 3 multiple changes of clothes with him to deal with that. And then when he presented to clinic, he was on a prednisone taper, one of many that he had done since I've seen him. He basically could not lower his dose beyond 20 milligrams. Once he dropped to 15, all of his symptoms would return: the diarrhea, the pain, the fatigue. He had been trying to manage his disease with azathioprine and mesalamine for years, and it wasn't successful. In April 13th, he had a calprotectin of over 500. The lab that he used just did that cutoff, and when I first saw him on steroids, he was at 333. Let's talk about how Crohn's disease often presents. About 80% of patients with Crohn's disease have some kind of small bowel involvement, usually in the distal terminal ileum, with 1/3 of the patients having ileitis exclusively with no large bowel involvement. 50% of patients have ileocolitis, small bowel and large bowel, affecting both the ileum and the colon. 20% of patients have a disease limited to the large bowel, and half of Crohn's patients with colitis have no disease in the rectum. 1/3 of patients have perianal disease, and 5 to 15% have involvement in either the mouth or gastroduodenal area, with fewer patients having involvement of the esophagus and the proximal small bowel. Hallmark symptoms include fatigue, abdominal pain, diarrhea, weight loss, and fever. Crampy abdominal pain is the most common manifestation of these patients, and it tends to be present regardless of where the disease is. It's a transmural disease, which means there's often fibrotic stricturing possible, and the strictures can lead to repeated episodes of small bowel and or possibly colonic obstruction. Diarrhea is common to have in Crohn's, but bowel movements will often fluctuate over a longer period of time. Diarrhea is associated with Crohn's disease and has the potential to have quite a few underlying causes. One is exclusive fluid secretion that is impaired by fluid absorption by inflamed small or large bowel tissue. Bile salt malabsorption is often common with these patients, where the small bowel, because of where their disease is, doesn't resorb those bile acids or bile salts, and that leads to diarrhea. You will often see steatorrhea secondary to that bile salt lack of reabsorption. Small intestinal bacterial overgrowth is common, and it's not unusual to see an overlapping IBS within these IBD patients. You could also see fistulas forming that will anatomically change the GI tract. It's not as common with Crohn's as it is with UC to see bleeding, but microscopic bleeding might be present. These patients don't have bowel movements of just blood, usually. Fistulas are also common in severe Crohn's disease. A fistula is basically a tract that forms between two different parts of the anatomy, either intestine to intestine, small bowel to large bowel, rectum to vagina, or topical to the skin around the umbilicus. Fistulas make the disease much more complicated and much more difficult to treat. This is a great picture of a fistula that's possible. What we see with Crohn's disease is this transmural inflammation. So basically this inflammatory process that takes up the width of the intestinal tract, which then can cause tunneling to get to different areas of the body. A phlegmon is another thing that we will see. That's basically a sinus tract. It's not a fistula because it doesn't connect to different areas, and it's not an abscess because there's no infection. It's just a leakage that goes into the peritoneal space that can cause problems and, more importantly, take up a whole lot of space. And then malabsorption is a big thing to know with these patients. So 80% of them have some kind of ileal involvement. And if we look at this picture put out by the Ostomy Foundation, what we see is very important nutrients, including B12, D, K, magnesium, and others are reabsorbed in the bottom of the small intestine. The terminal ileum is where the bile salts should be reabsorbed, but if there's disease there, then those bile salts will enter the large intestine. When they do, the bile salts will pull water and also stimulate peristalsis, which will basically cause a lot of diarrhea, but also a very fat, malabsorbed, fatty stool is the other thing we commonly see in these patients when they're severe. Steatocrit is actually one of the best ways to measure fecal fat malabsorption, and it is offered on the GI map test. It is not offered through conventional labs. This is one of the things that makes the GI map such a special panel. Steatocrit is a marker that has wide validation to show that it is a very good marker, taking a random stool sample to see how much fat malabsorption is present. The CDAI, or Crohn's Disease Activity Index, is how you'll see Crohn's disease documented in the literature, especially in the studies that we're reading. They'll use this very complicated score to tell you how severe the disease is. There are also very important blood tests for inflammatory bowel disease: a CBC, a chemistry, ESR, CRP, and then nutrients like D, B12, and iron are very important to test in these patients. And then there's a conversation that we have about imaging. Endoscopy, or EGD, is a procedure that involves sedation, and they insert a scope orally to visualize the esophagus, stomach, and small bowel. No prep diet is needed for endoscopy, and it's really there to rule out ulcers, esophagitis, or tumors in the stomach and very upper small bowel. Colonoscopy is the gold standard for diagnosing either Crohn's or UC, and what they do is they visualize through the rectum and they take biopsies to see how inflamed the condition is. There is a prep diet for this condition. They do use sedation and they do insert a scope into the intestine. The goal is to be able to enter the small bowel above the ileocecal valve to image the terminal ileum where most Crohn's disease lives. Back to Tim. What did we do for him? We ran a stool panel, the GI map. We started the specific carbohydrate diet after he collected his stool. We gave him 27 grams of glutamine daily and Saccharomyces boulardii at 115 billion in divided doses. Here is Tim's stool panel. It did not look good. Clostridia, Enterobacter were elevated. He had absolutely no Akkermansia, elevated Bacillus, Pseudomonas, Strep, fungal species. His calprotectin was elevated at 333, and his zonulin, or small bowel inflammatory marker, was elevated at 422.1. Shortly after that, he actually ended up getting hospitalized. August 16th, Tim started having significant increase in his pain and diarrhea, and he started having 12 plus urgent bowel movements a day. All of them were watery, loose, and he lost 8 pounds over the course of a week because he literally could not eat anything. He was in such severe pain. It's not uncommon to see elevated white blood cells, similar to what we see with him, lower iron or anemia, and then a change in the differential. When he was in the hospital, they ended up doing a scope and an MRI. And what they found was, if you look at the impression, which is on the bottom right part of the slide, you'll see wall thickening measuring up to 8 mils of enhancement of the distal descending and proximal to mid-sigmoid colon, consistent with the patient's history of inflammatory bowel disease, probable stricturing in the colon in the rectosigmoid region. The rectal wall thickening and inflammatory adjacent to the sigmoid colon, the studies were similar to a prior study. He also tested positive for C. diff, and so they started him on pretty aggressive antibiotic therapy, and he was hospitalized for 12 days and basically put on an elemental diet to try to get him into remission. On the elemental diet, after he finished it, then he was able to drop his calprotectin down to 119 because he literally gave himself bowel rest. Finally, the gastro was ready to start him on a biologic because Tim was so severe. They started him on infliximab, which is a TNF alpha inhibitor. He had 3 infusions, and after the 3rd infusion, he developed a very severe dermatitis that was so painful that he had to discontinue treatment. They switched the TNF alpha into adalimumab, and again, with that, he showed totally no improvement, even after using it for 3 months and going on and off the elemental diet. In September, the gastro switched him to an IL-23/17 inhibitor, and he had no significant improvement with his calprotectin then. Even at that point, it was up to 1,378. After it became apparent that Tim was failing his 3rd biologic agent, he was a little bit more open to starting to think about stuff outside the box. I started him on rectal ozone, N-acetylglucosamine, and glutamine. When we started treatment, I always take a baseline calprotectin, and he was at an 865. After the treatment, 6 weeks into it, we reran the calprotectin, and it had dropped to 112. He felt much better. He initially did ozone 3 times a week, and then he was able to drop to 2 times a week and maintain the N-acetylglucosamine and glutamine daily. And then we went back to get another colonoscopy for him. And this colonoscopy looked pretty drastically different than the initial one. The inflammatory bowel disease that was found with that possible stricturing was completely gone. They didn't note it at all. Inflammation was still found at the splenic flexure to the cecum, but it was mild in severity, and it was significantly improved based on the previous colonoscopy. Let's talk about why I did what I did. N-acetylglucosamine is a naturally occurring amino sugar precursor for the epithelial cells. It's basically a chemical that comes from the outer shell of shellfish, and it is made in a lab. And it's been shown effective for inflammatory bowel disease, osteoarthritis, MS, as well as GERD, or gastroesophageal reflux disorder. So what does N-acetylglucosamine do in the GI tract? Let's just take a quick big picture view. When there is some kind of aggravating issue in the GI tract, the GI will send macrophages to deal with it, that part of the immune system we talked about earlier. Those macrophages will cause a breakdown of the glycoaminoglycans, or GAGs. The breakdown of those GAGs will then release TNF alpha, which leads to a further breakdown of the matrix via the MMP system. And the continued breakdown of the MMP system leads to more breakdown of GAGs, which leads to more of an inflammatory cascade. The opposite of MMPs, or the thing that turns off that inflammatory cycle, is something known as TIMPSs. TIMPSs prevent tissue damage and are super anti-inflammatory. N-acetylglucosamine turns off the MMPs, upregulates the TIMPSs, and heals wounded tissue to decrease the inflammatory cascade. The NAG acts directly on the mucin layer of the intestines via the GAG pathway. The mucin layer is basically a thick layer that separates the intestinal microbiome from your enterocytes, and people who have intestinal inflammation or permeability have a much thinner or completely absent mucin layer that causes more irritation of the enterocytes, or the GI tract cells. The body, when you introduce NAG, it will uptake it pretty dramatically, and the NAG seems to decrease both pain and permeability within the intestine. It also seems to be very helpful for diarrhea and nausea alike. To dose N-acetylglucosamine, You want to give them 3 to 6 grams daily, and you can dose it either orally or rectally depending on where their disease is. Glutamine. Glutamine is an amino acid sugar. It's a building block of protein and a critical part of the immune system, and also integral to the intestinal health of the GI tract. It's actually the most abundant amino acid in the body, as well as present in other secretions as well. And it's the main energy source for our immune cells, white blood cells, and mainly our intestinal cells. A glutamine-deprived state will inhibit glutamine synthetase and can lead to decreased transepithelial resistance, increased permeability, and then reduced tight junction formation on a multitude of levels. There are 3, all of these being reduced can cause human cells to basically lead to GI dysfunction, and that dysfunction of the barrier will lead to glutamine being missing and the intestines being not at all healthy. When we dose glutamine, we are dosing it at about 0.5 milligram per kilogram body weight, and the data shows that after 2 months of using it, you could induce a remission in patients with Crohn's disease, as well as reducing intestinal permeability and change in morphology. Just so we're clear, about a 120-pound adult would need about 27 grams of glutamine daily, or 9 grams 3 times a day. To optimize care for these inflammatory bowel disease patients, the most important thing is to give them a very comprehensive treatment plan. Functional testing plays a critical role in managing your chronic inflammatory bowel disease patients. Microbiome testing is invaluable to show you what exactly is happening in the organ that is diseased in these patients. Food allergy panels and cytokine panels can help you make really good clinical decisions in refining not only diet, but also pharmacologic choice. And the tools of integrating and optimizing care can improve outcomes for patients and really help them recover and get back to optimal health. Thank you so much for joining me and watching this lecture on autoimmunity and inflammatory bowel disease and how we can utilize the diagnostic solutions, lab panels to really help optimize care for our patients.